Saying I'm having headache today. Don't worry, we'll treat your headache by the end of the class. Some genuine doubts coming up from the yesterday's class. Let me solve them together. Uh, Phenobarb is not the drug of choice for status. It was earlier used in pediatrics, but now they've also abandoned it to be used. Okay. And then in which type of seizure foaming of saliva at the mouth is seen? Yeah, it is commonly seen in a patient with GTCS. In generalized tonic-clonic seizure, we get foaming of saliva. That was Dr. Bhumika who was asked this doubt. Mohammad Iyaz has got a doubt, sir. If I put the patient in the left lateral position, as you told yesterday, won't the patient aspirate? See, the chances of aspiration are quite less in that posture, because the right bronchus was more vertical than the left one. If I place him in the right lateral, obviously they're going to aspirate. Correct? Sorry. Uh, Dr. Siddharth Kothari has asked a doubt. Can exogenous progesterone therapy be used to decrease seizure? Yeah, somewhere we use it. In females, on the Facebook club, some of the students asked me, sir, if a female is in a perimenstrual phase, can she have more seizure at that time? Yes. That's known as catamenial epilepsy. So in that cases, we try to supplement it with the progesterone, so because it is going to increase the seizure threshold enough. Okay, so it can help. See the clinical picture. There's a lot of doubts I've seen on the Facebook club also. There is a doubt on temporal lobe epilepsy. The very first doubt which came with everyone's mind. So where do you put temporal lobe epilepsy? So do you put it under focal or do you put it under generalized? Actually what happened while writing, after JME I put it. So everyone thought, yeah, it's a generalized. No, 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 no. Let me clarify this. Temporal lobe epilepsy commonly presents with focal seizure with impaired awareness. So we will always try to put it under focal. But the problem is they are not responding to the medical line of therapy. So the treatment is entirely different. It's non-pharmacological or surgery that you know. Okay. Barbiturates were earlier used in patients of status. Now they are no more using it. Okay. See, Dr. Shibin Sankar has asked a doubt, sir, why should we change a female from valproate to levetiracetam in JME? See, fertile female can conceive in any cycle. Valproate I know can cause neural tube defect, although I give folic acid, but that doesn't give me surety it won't happen. So why not put the patient onto a drug which is less teratogenic and possibly in the first line of treatment of JME patients. So there is nothing wrong. We can start on them with levetiracetam. Okay. How to prevent tongue bite? Yeah, it's very difficult. I told you yesterday also that tongue bite is something which will happen in spite of all the measures that you take. So what we can do is put a mouth gag. Yeah, mouth gag we do use nowadays, but we use it in the post-ictal phase. Because in the ictal phase, when the teeth are so much clenched, it's very difficult to introduce a mouth gag. And in that particular tonic phase, if you put a mouth gag, there are high chances of laceration on the tongue and the soft palate. So there's no point in this. Okay. Yeah, imaging. Dr. Yashaswini Srivastava has asked us out that can imaging differentiate typical with atypical? Yes. See, typical, the imaging was normal. Atypical will have some structure abnormalities, but more important is EEG. If you remember, 2 to 4 hertz spike and wave for typical, less than 2.5 hertz for atypical. Okay. Oh my God. Okay, let's start the topic for the day. Please, please, please. Your doubts are most welcome. Most welcome. I've already put a Facebook post yesterday in the 2020 Club of Dams with the meme also. Okay. So clear your doubts there. That is a better medium to clear the doubts. See, it's your chat box is scrolling like this. It's causing a vertical nystagmus in me. So if I get up, I might have a syncope. So let's start with the topic today. I'll answer all your doubts on Facebook. I've been active every 2 minutes. I'm seeing the Facebook. Okay. Okay, let's start. So keep calm. The class will start at 7. Yeah. The COVID-19 pandemic. Someone asked me what's the full form of COVID. I said Chinese originated virus in December 2019. I thought made in China kind of things don't live long. But unfortunately, I was wrong this time. Things which are made in China are now working very well all across. Right. Chalo, let's start the day. Let's start with a very important topic and a very important symptom of various kinds of clinical disorder that we find, known as headache. Headache. We do come across this kind of a symptom very often in our clinical practice, and I'll tell you one thing. Is that the headache is something which is going to give you headache, because the patient of headache comes and tells you with a lot of psychosomatic symptoms, and to our doctor to understand and catch the actual disease is a big headache. So it's very important clinically also when you come across in the OPD. Nowadays, if I do an OPD, I'm not doing it right now, but if I do an OPD, at least 3 to 4 patients of headache have come to me in a day. Pre-lockdown, of course, I'm talking. Now, how do we classify headache? Now, the first important thing, how do we classify headache, and why is it important to classify a patient with headache? See, the classification of headache has been done on one thing, the cause, the etiology of the disease. So there is a etiology of a particular disorder like headache as a symptom. If etiology is present, or maybe the etiology is not present in the case. Remember this, if the etiology is present, we always label this as a secondary headache. And if the etiology is not present in a particular headache, we always label this as a primary headache. So these are the two broader classifications of any kind of a headache that we find. If there is a cause, we will always have a solution to it. That means secondary headache will always have a solution with it, while the primary headache won't have it. It will always be a problem with it. Okay. Now, what are the cases of secondary headache? Like number one cause. Now I'm mentioning the causes of headache. First, number one cause of the secondary headache that we find is the systemic infections. Remember this. Systemic infections happens to be the most common cause of secondary headache. That's why I'm putting it as number one. Second, after this, we find head injury also, a leading cause of secondary headache. Yeah, this is the first slide. People who are asking me, this is the first slide. Just keep on writing here. Third one is the vascular disorders that we come across with. Vascular disorders. Okay. Number 4 is subarachnoid hemorrhage. And number 5 is your brain tumors. Brain tumors. Okay. So I mentioned the causes of secondary headache, acquired causes which have a solution with it. And look at this. I've seen this as a very common scenario, that a doctor or a medico gets headache. He thinks that he has got a brain tumor. Let me tell you, my dear friend, brain tumor is number 5 cause of secondary headache. Before the brain tumor could actually happen in you, a lot of things are yet to happen. Okay, so be careful. Now let's look into the primary headache causes, or the types of primary headache that we come across with. The number one is the tension headache. Tension headache. Okay. Number 2 is your migraine. Okay. Number 3, it's idiopathic stabbing headache, idiopathic stabbing headache. Number 4 is exertional headache, and number 5 is your cluster headache. Cluster headache. There's some color variation, I have intentionally put it there. Primary headaches, when we come across, are more frequent in females, except for one headache which we'll deal at the end, cluster headache, which is more frequent in males. Okay, we'll come to that, don't worry. But if at all asked in the exam, please do remember this. Most common cause of headache, primary when I look at, okay, is always a tension headache. Tension headache is the most common type of primary headache. But when I look at the headaches which are secondary headaches, yes, the most common cause is always a systemic infection. Systemic infection. Don't forget this thing. Now, let's look into everything. But before that, it's always mandatory in neurology that we read to see the basics first, the anatomy and the physiology part. So, there are some structures which are present in the cranial cavity, and don't forget these structures present in the cranial cavity can be in two heads. Either the structures can be pain sensitive, or this structure could be pain insensitive. Two things could happen. Either it could be pain sensitive, or the structure in the skull can be pain insensitive. Genuine doubts, overall cause, if I ask, overall. See, there is no literature on the thing overall. But my belief is that the systemic infection is more common than anything else. And those patients come to us with headache. Okay, so it's very difficult to pinpoint on the overall cause. It's very difficult because it's all a case-based study which may be different in different hospital or OPD. Okay. Now, sensitive and pain insensitive structures inside the cranial cavity. Remember this, the pain insensitive first. The pain insensitive structure inside the cranial cavity is the ventricular ependyma. Second structure is choroid plexus. Choroid plexus. Number 3 is the pial veins. And then we have the actual brain parenchyma, which happens to be another structure which is pain insensitive. Don't forget this. Okay. Now, pain sensitive structures, we'll make a list of that also. In the pain sensitive structures inside or outside the cranial cavity, number 1 is the scalp. The outer covering or the skin over the skull, the scalp happens to be a pain sensitive structure. I'll come to your doubt. One doubt is coming that migraine is under primary headache. Why? I'll come to your doubt. Let me discuss migraine, then I'll tell you the whole story. Meningeal arteries. Meningeal arteries. Okay. Dural sinuses. Dural sinuses. Number 4. Falx cerebri. And number 5 is the proximal segment of large pial arteries. Now have a view on this, that the pial arteries are considered to be pain sensitive, while the pial veins on the other end happen to be pain insensitive. Okay. Dural sinuses, meningeal arteries are very important structures which are seen to be pain sensitive structures inside the cranial cavity. Don't forget these things. This is something very high when it commonly asked. Now, before we go into further, a bit of anatomy again. When I look into the nerve supply inside the cranial cavity, how do I see the nerve supply? Now, let me make this out. A skull, which has been divided into three parts: the anterior, the middle, and the posterior cranial fossa. So there are three cranial fossas that you know: anterior, middle, and the posterior cranial fossa. The anterior and the middle cranial fossa happen to have a nerve supply that they are going to carry the pain afferents from there through the fifth or the trigeminal or the fifth cranial nerve. And most important, the posterior cranial fossa will be the first three cervical nerves. So anterior middle cranial fossa is through the fifth trigeminal nerve, the nerve supply, and the posterior cranial fossa, which is infratentorial, is through the first three cervical nerves. Okay. Now let's go into a secondary headache, or rather a disease which can be presenting to us with a headache very often. That is known to me as a very commonly asked topic: giant cell arteritis. Giant cell arteritis. Okay. Now don't forget, this giant cell arteritis as a disorder is well known to me as a disease in which I find inflammation in the medium and the large sized arteries. So the medium and the large sized arteries which are supplying the brain, or maybe outside the brain, outside even the skull, you can have this problem. Medium and large sized arteries are commonly inflamed in them. And another quick fact, if you remember this topic, it's commonly seen in the elderly population, yes, and it's more frequently seen in the female than the male population. It's more frequently seen in the female than the male population. Another quick fact. Now, another line which is given in the books is that giant cell arteritis, or a disease, is found to be exclusive for age group, that is, the age group of 50 years plus. So people whose age is above 50, it's quite exclusive for those kind of people. So it's not commonly seen in the adolescent and young adults. That's the message. Also, we do know is that the most common artery involved in them, yes, I hope you know, most common artery involved in giant cell arteritis to us is the temporal artery. That is the most common artery involved in them. That's why the disease is also labeled and read in the book by another name as temporal arteritis. Okay, itis of the temporal artery. Now, when I want to look at the disease like giant cell, I'll go into temporal arteritis chapter and read it from there. Now, clinical features when I look at the disorder, it's headache as a symptom that we find in the patient. Now, the quality of headache is very important now. The quality of headache that you can find in the patient could be throbbing, one, or could even be stabbing that you find. Why? Because possibly the temporal artery which is flowing with blood is now inflamed. So whenever the blood comes into the arterial lumen and the wall is inflamed, what will happen? I'll feel the blood coming in. So it is pulsatile throbbing, and the temporal artery, remember, it's superficial outside the skull. So it seems as if someone is hitting me from outside, stabbing. Now I'll ask you a very easy question. Can you tell me a differential diagnosis in a patient with a stabbing chest pain? A patient has come to me with a stabbing chest pain. What is a differential diagnosis? I'll give you this clue. It's a dumb charades, you know. It's chest pain, tear in the chest, stabbing. What can be the disease? What expected disorder? Stabbing chest pain. Can be interscapular in the back also. Not MI, my dear friend. MI will have a pain which is increasing on exertion, like someone has put a stone, a very heavy rock on the chest. Yeah, people are answering me correct. Aortic dissection. Don't forget this. Aortic dissection. Yes, aortic dissection is something that you should all know. It can come intrascapular. I agree, MI. The typical MI pain is not stabbing. Aortic dissection, I'm asking, is a typical stabbing chest pain. Okay. Now, apart from this, in the patient of giant cell arthritis, you can also find in them entity known as scalp tenderness. Scalp tenderness. Why? Because when we touch upon the scalp, we actually touch upon the inflamed artery, that is temporal, and you find the pain slightly increasing on touch because that artery is inflamed. Okay. Along with this, in the patient, you might also find a very classical symptom of jaw claudication. Jaw claudication. Now, find this name claudication from your surgery books. It's a pain which occurs in a part of the body if the vascular supply is compromised. Correct? Now, you know the temporomandibular joint is something which is being supplied by an artery, temporal artery, and that artery is inflamed, temporal arteritis. So what will happen? On movement of the jaw, on movement of the jaw, the pain in the patient would increase. Okay? But at rest, that means when the jaw is not moving, in the patient the pain will actually disappear or decrease. So the pain increases on movement due to insufficient vascular supply. That's a very classical symptom known as claudication in clinical practice. And jaw claudication, pain on movement of jaw, occurs in these patients very specifically. Okay. Along with this, don't forget, temporal arthritis patients do complain to me with a very different entity known as polymyalgia rheumatica. Polymyalgia rheumatica. Now, what is this polymyalgia rheumatica? In these patients of polymyalgia rheumatica, there is pain as well as stiffness, which is felt on the patient's back, on the neck region, or even over the shoulder region. So pain and stiffness on the neck, back, and the shoulder region is very typically felt in these patients, and this is known as polymyalgia rheumatica symptom. Now, just to know this fact, around 40 to 50% patients with giant cell or temporal arthritis even could present with this kind of a symptom, polymyalgia rheumatica. Okay. And just to add to any itis, you might have constitutional symptoms like fever, weight loss, and all those drama in any inflammatory disease would also happen in these patients. Okay. Investigations. Now, in the investigation part, do remember this. One thing very important that I might look into is the complete hemogram of the patient, which might show a raised ESR. Because it's an itis, it's inflammation, the ESR is bound to rise in these patients. Okay. But the tissue diagnosis is most important to claim the disease. That is nothing but my temporal artery biopsy that you might do in the patient. Now, few points that I note in the histological image or the slide of a temporal artery biopsy in these patients. One thing is very clear. These patients are going to have inflammation in every layer of the vessel. It's known as panarteritis. So it might start in the adventitia, go to the intima and muscular layer. Every layer of the artery is equally involved. It's a panarteritis picture seen in there. Along with this, don't forget, in these patients you might see big cells, which you know as the giant cells. That's the name giant cell arthritis given to it. Okay. Now, ideally speaking, what is the length that we take out for the biopsy of this temporal artery biopsy, the length of the specimen to be taken out. Now, length of this specimen to be taken out is somewhere 3 to 5 centimeter. Again, this has been a bigger controversy that I could have ever imagined. In Robbins, I remember it still gave 1 centimeter. In CMDT medicine, it's given 2 centimeter. But can you tell me who is the main author in medicine? Harrison. That's the Kal Granth of medicine. So all Guruji ke Sandesh is given over there. So the Bible of medicine is a Kal Granth is always Harrison, right? So in Harrison, we'll take it as 3 to 5 centimeter. Okay. Now, a question came in quite recently in one of the exam that what is the ideal length to be taken out for the biopsy of the temporal artery? Okay. The options that were given were very crazy, you know. The options were 2 centimeter, 5 centimeter, 4 centimeter, or 3 centimeter. Now, I want your answers on this. A, B, C, or D. 2, 5, 4, or 3. They may just mention like this. You know, what is the ideal length of the specimen to be taken up for the biopsy in temporal artery biopsy? What's your answer? 3, 4, 4, 3, 4, 4, 4, 4, 4, 4, 4, 4, 3. Most of the students I can see in this chat box also are answering me 4 centimeter. When I ask them why 4, so I took out the average. Average is 4. Oh my god. This is not the community medicine stats question that you need to require a mean, median, mode over there. My dear friend, the best answer should be always 5 centimeter, not 4. Now I tell you why. Why not even 3? And of course never 2. Because you know the arthritis picture in these patients, it's not all over the artery. It's quite often found to be a patchy involvement. It's not a diffuse, it's a patchy involvement seen in them. That means the itis part which I'm mentioning, the inflamed part, is seen here and here. And between these two segments, it could possibly be normal also. So you might take out 3, you might take out 4, you might miss out the disease. So bigger the length, more is the chances of finding the disease proper. Okay, remember this fact. So this kind of a patchy involvement in patients of temporal arthritis has got a different name. Segmental lesions. Segmental in the sense a particular segment is involved and there may be an area which is perfectly normal between the two segments. So if such a question comes in, please don't mark 4, don't take out the average, don't show your intelligence there. I know how intelligent you are. Mark it as 5. Okay. Now, we will follow the patient for treatment also. Okay. Now, one thing I just forgot to mention. I'll take you back slightly in the clinical features. I just forgot to mention this. You can go back to the clinical features and write one more symptom I just forgot to mention. That is blindness. Yes. Blindness can be a symptom of temporal arthritis. Now, temporal artery actually doesn't supply the eyeball. Why will blindness occur? See, it's not only the inflammation of temporal. Other arteries could also get involved in the disease process. Now, an artery known as the posterior ciliary artery. The posterior ciliary artery involvement causes this problem in them. Okay. But remember this. Blindness in any patient of temporal arthritis is a very bad sign. Why? Because this blindness, if at all happens, will always be irreversible. We have never seen a patient of temporal arthritis recovering back completely when they got blind. Okay, so the blindness is always considered to be irreversible in these patients. So that's why we are afraid of blindness as a symptom in temporal arthritis. Okay, now let me go into the treatment part. The treatment is very clear and very simple, very straightforward. we have to supplement a drug which is going to decrease the inflammation, and Ramban, a drug of choice, or Ramban maybe. We're watching Ramayana nowadays, no? So Ramban for any itis is always a steroid, and one steroid really helps me out. One steroid really helps me out, that is prednisone. Now prednisone, whenever is given to these patients, it's given in a dose of 40 to 60 mg per day. Okay. For a month duration, okay. And then tapering of the steroid to be given further or not in the patient is guided by the ESR. So if the ESR is coming down, we might taper and stop the drug therapy. But remember this, that one thing is clear. In patients of temporal arteritis, steroids as a mainstay of treatment are required for a duration of more than 2 years at a stretch. Although you might decrease the dose, but it's not always the patient is off the steroid. They're always on steroid at least for 2 years and plus duration. Okay. And don't forget another point to be noted here, if visual loss is seen. Now, if the visual loss as a symptom of blindness is seen in them, then I'm really worried. I have to stop the progression of that thing. So why not give a drug which is injectable steroid? If you go and see the injectable steroid, a very powerful one happens to be my methylprednisolone. Now methylprednisolone is given to the patient at a dose of 1 gram per day for at least 3 days at a stretch. But methylpred to be given in the patient only if the patient complains of a visual loss. Okay. Now a student asks a genuine doubt, sir, is the visual blindness sudden? No. I've seen patients of temporal arteritis. I'll give you my story later on. But you know, very common, I've seen these patients. These patients come to me with a transient loss of vision. That is happening on your screen also. Don't worry, it is recovering. Okay, I know it's a black screen. Don't worry, it is recovering. Can you tell me what is this transient loss of vision known as? Can you tell me the name of this disorder? If you have ever read it in Opthal, please tell me. Yes, very good. Manish Talkar, Anand Talkar, okay. Rax Fugox. It's Fugax. Yeah. Actually, I myself, it's Amaurosis Fugax. Actually, I'm a very smart teacher. I just forgot the spelling of this thing. So I made you write the spelling and I'll copy paste it. Okay. I just forgot the spelling of this Amaurosis Fugax. You know, some Firago is there in medicine. So I made you write. Okay. So the moral of the story is that they may not come with a sudden loss of vision. They might come with a transient loss of vision in between. And if I find these patients in my OPD, it's always better to put them on a methylpred kind of an injectable therapy. Okay. Yeah, methylpred is given through the route IV. Someone is asking me that. Okay. I know James is cheating, but chalta hai, some cheating is fine. Now, aspirin. Okay. Don't pull my leg, yeah. I was myself a damn student in year 2005. Long back. Whatever you are doing, I always have done the tricks on my teacher. Okay, you know, in Hindi they say saas bhi kabhi bahu thi. Okay. Aspirin. Aspirin is an antiplatelet or maybe inhibiting the thrombogenic phenomena. Remember this aspirin has to be given to the patient if the patient is coming to me with any kind of a chronic ischemic complication. Right? So chronic ischemic complication means it can be a jaw claudication, it can be a simple blindness. So please give an aspirin tablet also if you come across with such symptom. Another drug that has come in is the old drug, the immunomodulatory drug, tocilizumab. Tocilizumab. Okay. Tocilizumab is actually is interleukin 6 inhibitor. Interleukin 6 inhibitor is tocilizumab. It can be used and it's FDA approved for the patient. Okay. So this is the standard line of treatment of giant cell or temporal arteritis. I'll just write this question down, which has come quite recently in one of the exam. They asked like this, write it down. A female is complaining of a throbbing headache. She complains of a throbbing headache with pain on movement of jaw and of course a raised ESR. Now the question frame was this: what next are you going to do? The options that we have with us is A, advise biopsy, then start steroids, or straight away start steroids. Okay, tell me please, what's your good answer? Yes, start steroid immediately. No problem, no problem. Advice for biopsy, wasting time for the report is not good, because if I leave the patient without any kind of a treatment, the patient might turn up in the next visit in the OPD with blindness. Now all is gone now. So don't wait for a biopsy. Start with steroids. Now one student was getting emotional on this. He asked me, sir, how are you going to do biopsy? Do we do in a good setup? Yes, we do it. But the problem is the limitation is always there. Somewhere the patient is not willing for all these kind of thing. So it's always better to start on steroid, then go for a biopsy. Giving a steroid won't really change the picture in the slide of the histopath or biopsy. You can get it done later on also, no problem. Now, a student asked me, sir, what about methotrexate and infliximab? Someone asked me, methotrexate and infliximab. Two drugs, please. No benefit. Earlier editions of my textbook used to mention these drugs over there. No benefit, no benefit. They have run a lot of trials, not too much of benefit. It's always questionable. Some centers do give methotrexate, I know them, but not too much of benefit has come with it. Okay. So that's about temporal arteritis, a very simple and a very commonly asked topic in the exam hall also. Now let's go and see another disease. Okay. See, if I give steroids and then later, if the time permits and the patient agrees and the doctor agrees, I can do over a biopsy. See, steroids for at least 14 days, okay, does not change the biopsy picture. This is light given in Harrison. Even if you give it for 2 weeks time, it won't change with biopsy picture. Okay. श्रीधर भरत भाई मकवाना, सरस छे भाई. Because some people I have noted down today, I'll throw them out, don't worry. Pseudotumor cerebri. Pseudotumor cerebri. Pseudotumor cerebri. Okay. Okay. Now, pseudotumor cerebri is another topic. Yeah, we do find a palpation on the scalp region, a cord-like thing. Okay. See, transient loss of vision is fully reversible, no problem. So transient loss of vision means transient, it's fully reversible. If I don't treat that kind of a symptom, the patient might go blind. Okay. Pseudotumor cerebri. Now, write this down. Pseudotumor cerebri, another headache, is most commonly seen in young, obese female. In females who are young and obese, they are more likely to have it. Okay, so don't forget them. They more commonly have this kind of a problem. Now, when I look into the clinical symptoms of pseudotumor cerebri, and why is it known as pseudotumor cerebri? We should know this fact. Why is it known as pseudotumor cerebri? Because it is behaving like a tumor, but it's not a tumor inside. It's a triad which comes, a love triangle of the symptoms which come to define this disorder. The very first thing is headache. Second one is papilledema. And the fourth one in the patient is no focal neurological deficit C. Please remember this. These patients are behaving like patients of a brain tumor. Any patient with a brain tumor will have what? Raised ICT. This patient also has got raised ICT. Now the problem is it's a headache of the raised ICT seen in them. Okay, there is some emesis fugax right now. Don't worry, it will recover. Don't panic. Don't type on the chat box. Okay, it's reversible phenomena. In DAMS E medicos, emesis fugax is transient. Okay. Now, headache. Now, headache is something which is of raised ICT. And don't forget, in patients of pseudotumor cerebri, the initial symptom that we find for the disease is very commonly headache. And it often increases on awakening, and it is more in the morning time. It's more often in the morning time that we find. Okay. So it's more commonly seen more often in the morning time on awakening time, and it's an initial symptom in the patient. Now look at this. Whenever you see a patient of raised ICT, remember this fact. Fundus is the mirror of the brain. That's right. So anything of the raised ICT, okay, will be reflected in the fundus of the patients. That is known as a optic disc coming up with blurring of the margin, known as papilledema. And don't forget this no focal neurological deficit, because there is no tumor actually. If the tumor was in the frontal lobe, we could have a behavioral problem, parietal, sensory, temporal, memory, no problem. There is no tumor, so there is no focal neurological deficit as such to consider that there is a tumor inside. Due to unknown reason, I am quoting again unknown reason, the book mentions that they don't have a typical hydrocephalus scene. So the ventricle size in these patients is perfectly normal. That's very important. ICT stands for intracranial tension. Okay. Now, when I look into the disease proper etiology, what is the reason behind this disease? Number one, idiopathic. The most common type of pseudotumor cerebri, that we find is always idiopathic. That means we don't have an attributable cause given for it. That's why if you open up your books, standard textbooks, they never mention the word pseudotumor at all over there. Now what is this? That the disease pseudotumor is also given a new name. It's known as idiopathic intracranial hypertension. So there is a raised ICT, there is IC. IC stands for intracranial, HTN stands for hypertension. So without any reason it happens most of the time. So you'll never find a term as pseudotumor, it will always be read as a term idiopathic intracranial hypertension. Okay. Second thing that you find is cerebral venous hypertension. So there is increase of pressure in the cerebral veins, if you remember, as a cause. Why? Because in this kind of cases we find there can be a direct or maybe an indirect occlusion of superior sagittal sinus. Why? Why would it really cause the whole problem? Yeah, someone is asking me raised ICT because of decreased CSF absorption. Good. Now I am coming you to your doubt. Why decreased CSF absorption will happen? If you remember the CSF, yes, CSF is formed in, CSF is absorbed in. Where is the CSF formed, if you remember? The great plexus, choroid plexus. Where is the CSF absorbed in? It is absorbed in the arachnoid villi. Now if you remember, where are these arachnoid villi present? These arachnoid villi are present very well in the superior sagittal sinus. So these arachnoid villi are projecting into it to catch the CSF to get it absorbed. Okay. So if there is occlusion of this sinus, there is occlusion of the arachnoid villi, and what will happen at the end? Yes, we're going to have what? Decrease in the CSF absorption. It's a very clear statement. So whenever, remember this simple funda, that whenever you have a raised ICT, most of the time the disorder is due to decreased CSF absorption. It's a very common connecting link. But why will this superior sagittal sinus occlude? Now there is a reason behind this. Because this sinus is not the paranasal sinus, this is dural sinus, okay? And the blood is coming there. So it can happen due to certain kind of a hypercoagulable state. Hypercoagulable state. Now what hypercoagulable states you know? To be very clear and very common in them, we have malignancy. Common, I am telling you, common ones. Oral contraceptive pill, and maybe rare to rare is the APLA syndromes. So antiphospholipid antibody, or yeah, pregnancy also you can include here. Good. So these are few things which are considered to be a hypercoagulable state and can cause this whole drama, right? Then we have another important cause tonight, which can be meningeal disorders. So certain kind of meningeal disorders or diseases could again cause this disease. Why? Because the dural sinuses are now inflamed by some kind of a disease affecting the meninges. Now what can be the disorders? Meningitis, inflammation with infection of the meningeal layer, meningitis itself, which can be infective, non-infective, acute, chronic, whatever thing you want to think about, right? Now number four is iatrogenic. Don't forget this word iatrogenic. This is something very, very, very important. Due to certain drugs, I can have this kind of a problem. One thing is hypervitaminosis A. Hypervitaminosis A. Excess of vitamin A given to anyone can cause this kind of a disease. Second, could be exposure to certain drugs that we use in our clinical practice, like tetracycline analogs, even quinolones, even estrogen, lithium. See why all these things are causing this kind of a thing. It's not very clearly given in any of the books, but it has been a common association with this disorder, iatrogenic cause. Okay. Now number five can be a metabolic kind of a thing, metabolic disorder. Now in the metabolic disorder, yes, we have with us hypoparathyroidism, hypoparathyroidism, and hyperadrenalism. Okay, so it can be Cushing, it can be Addison, hyperadrenalism, or it can be hypoparathyroidism. PTH stands for PTH parathyroid. Okay, see, how is obesity related? I could not find a good reason, because I have also seen many females with this disease, and it's very common in the obese females who are young. It was just a chance that we found this disease to be more common in them. Okay. No, hypervitaminosis D. No, I don't think so. D. It's A. A. I'll tell you my experience on this. Hypervitaminosis A. I always tell this story in my live classes also. I was in my internship, and interns are Kabir Singh. Yeah, they are rebel without a cause sometimes. And I was in the internship, and I was posted in pediatrics. So I went to the pediatrics OPD to report over there, and I was immediately sent to the immunization clinic, because there's no good work to be done there. So I went to the immunization clinic. I was making all the growth charts, everything. And I found the nursing in charge over there was dispensing vitamin A to every kid. So it was a part of the supplement, or a blanket therapy to prevent night blindness in the low socioeconomic strata. And how do you dispense vitamin A if you work in the ward or OPD? You will come to know it's not injectable. It's a syrup kind of a thing. So I was just pouring the syrup into a spoon and giving it to the mother. And suddenly one mother who was very over intelligent asked me a genuine doubt, "Doctor, what are these drops you are giving in a spoon? Are they polio drops?" I said, "No, madam, they are vitamin A drops." Then she questioned me that, "Why do you want to give it to my child?" I said, "If I give vitamin A to your child, possibly he will have a good vision." Now, the mother was over intelligent. What happened? She thought the vision of the child is very good. Let me fit MRI into his eyes. MRI into his eyes. And she took 3-4 bottles of vitamin A syrup home. And every morning she used to feed the child with the same vitamin A syrup, thinking one day he will grow up as a radiologist. And to my surprise, the same kid, after a long term and a heavy dose of vitamin A supplement, came back in the emergency few days later with headache, papilledema, or signs of raised ICT. So that's the story of hypervitaminosis A. Don't forget it. Okay. And I was saying in Hindi, got very correct. माँ का प्यार अंधा कर सकता है. The mother's love can make you blind because of papilledema. Right. Now, when I go in for the treatment, see, whatever story or the clinical kind of a thing that I have told you has been asked as an MCQ. To your surprise, open your guidebooks. 3-4 years back in PH and AIMS, we got the same kind of a question there. Yeah, the same storytelling was done there. Okay, right. Now let's look into the treatment part. Not too much of good drugs available with it. Yeah, it's a real story. I'm not faking it. Yeah, I know the fiction is a part of neurology. It's a department of neurology. So some spices and some reality is always there. Okay. Acetazolamide. Acetazolamide is a drug which is causing decrease in the CSF formation. Decrease in the CSF formation. Decrease in the CSF formation, acetazolamide could help in the patient, right? There's not too much of treatment available with us for these kind of patients. Some of the things that we could learn from neurosurgery was this. We can go for a lumboperitoneal shunting. Lumboperitoneal shunting could be done in these patients, known as LP shunt. Why you want to put this shunt now? We take the CSF out. We take the CSF out from the subarachnoid space, putting a shunt over there in the lumbar canal. And now we divert the CSF into the peritoneal cavity. Now look at the concept. The main reason, as I told you earlier, was decreased CSF absorption. So CSF absorption is delayed in them. So let me get it absorbed into a place where it is 100% in 24 hours absorbed. That's my peritoneal cavity. So we do a LP kind of a thing, lumboperitoneal shunting kind of a surgery. Okay. Right. Now let's move into another headache, which is the primary headache, tension headache. Some student is continuously asking for doubt. Dr. Hardik Punjabi. The doubt is break, sir. Break, break. Arey Baba, 2 hours class with so much jokes. Why you want to take break? Okay. Chal Madi, study in the class. Okay. Tension headache. Tension headache. Now, I already mentioned this point. Most common primary headache is a tension headache. Most common primary headache is a tension headache that we find. Tension headache is something which is more frequent in females than males. Please don't remember this fact. Okay. How long is this LP shunt being put? See, that's why I'm telling you, neurosurgeons are still in a workup kind of a thing. They are still doing it, but we don't require that much. I've seen patients of pseudotumor very often in our OPD. Most of the time we see that the patient settles with acetazolamide. There's not much of a problem with them. If the patient doesn't respond, I can write this, if there is a poor or no response, then we might send him for a neurosurgical advice and go for this kind of a thing, lumboperitoneal shunting, but not routinely done. Okay. Now, tension headache. Tension headache is more frequent in females than males, and it's the most common primary headache. Okay. Okay. Now, remember this point that this tension headache as a disease is very commonly associated with depression. Commonly associated with depression. And I'm writing this also in bold that tension is not an etiology at all for it. It's not a cause for this kind of a disease, although it's known as tension headache, but tension has nothing to do with this kind of a disease. Why still it is known as tension headache? Reason? Because in these patients we often and commonly see headache, which could be in a description of the patient as dull aching, and it could be band-like kind of a thing. So it can be a band-like sensation felt on the patient's head, which is all constant dull aching, right? So you know what happens is that the presentation of the patient is like this. They do tell me that in the frontal region, temporal region till the occipital, okay, there is a constant force of constriction like a band being felt. Okay, this is a band-like dull aching sensation felt in the patient. And let me complete the diagram. They are not very happy. As I mentioned, they are in depression. Okay, so that's a very depressive phase. Along with this, the treatment. Okay, so let me clear this. Why is it was known as tension? Because on the scalp region there is increased contraction on the muscles felt. There's a lot of tension in these muscles felt. That's why we label this as tension headache. Now, treatment part. It's very simple. Either the headache that we come across is episodic or it could be chronic. Correct? Episodic headache of tension headache is known to survive or remain for less than 15 days in a month, while the chronic wala lies there or remains for more than 15 days in a month. Okay. Now, episodic tension headache doesn't require too much of hurry. So, we just give painkillers or analgesics to these patients. While the chronic tension type headache, we offer giving them tricyclic antidepressant, TCA, that is amitriptyline. Now, don't forget the drug of choice if they ever ask you. For patients of tension headache, it's going to be a tricyclic antidepressant, amitriptyline. Why? Now, people ask me what is the etiology of tension headache. Look at this now. That the patient is not having any clear etiology. That's why we classify the tension headache under the heading of primary headache. But one thing we found in them, that the depression was a very constant thing. So why not treat depression by a tricyclic antidepressant, amitriptyline? It will really help the patient, right? Okay. Now, some doubts have come in on pseudotumor cerebri. So how do you go about diagnosing that disorder? See, the headache with raised ICT, peptidema, no focal deficit, and no hydrocephalus also on a imaging will mean a case of pseudotumor cerebri. Then most of the causes are not known, it's idiopathic. But if you want to see the causes, you have to search for the causes which we wrote together. Okay. Now, why does decreased CSF absorption this time not cause hydrocephalus? That's another doubt which has come in the student's mind. I again mentioned that why hydrocephalus is not seen, it's not clearly given. They say it's all due to some unknown reason. Okay. Right. Apart from this, another very important topic, that's migraine. Migraine. Don't forget, migraine as a disorder, it's more frequent in females than males. As a disease entity, I don't never forget this point, that it is more frequent in females than males. Okay. Now, remember this concept that migraine headache, whenever I want to see, okay, will always have a typical diagnostic criteria. To define it as a migraine attack. See why it is called as a tension headache, because the patient feels a lot of tension on the scalp muscle due to contraction. That's why it is known as tension headache. Okay. Now, diagnostic criteria. The diagnostic criteria for migraine is that the duration, the very first and the foremost thing, the duration of headache that we find is found to be between 4 to 72 hours. So very common experience in the OPD that we attend these patients of migraine. The very first thing is that we ask the patient history. He comes and tells me that, doctor, for the last 2 or 3 days, the headache is always continuous in the patient. So that's a very important thing. It is very for a long duration, 4 to 72 hours. You want to understand the treatment of tension headache? Yes. Tricyclic antidepressant, some amaurosis fugax has just happened. Don't panic, all is well. I'm back. So, tension headache, if it is episodic, less than 15 days in a month, you give simple painkillers like analgesics. Chronic wala will require a tricyclic antidepressant, amitriptyline. Now, amitriptyline dose is variable. Someone is more concerned about the dose. Dose of amitriptyline is 10 to 25 milligram per day. So 10 to 25 milligram per day is a dose of amitriptyline that can be variable. Okay. Migraine. Now, migraine is something. Analgesic can be a simple painkiller. Any painkiller could help in the patient. Okay. Migraine. The migraine is something that we know is the duration 4 to 72 hours, right? Okay. Apart from this, don't forget the quality of headache that you come across in them. That is puma. Puma is a quality of headache that we come across in these patients. The word P stands for the pulsatile. U stands for the unilateral thing. M stands for moderate to severe in intensity. So what is the meaning of this? Moderate to severe in intensity. That means this kind of a headache is causing some kind of a functional impairment in the patient. That means maybe because of headache, what we find in the patient, they cannot come out of bed, they cannot go to work. So some kind of functional impairment is there in the patient. Very well. And the last A goes for aggravation on movement. So when the patient moves around, the pain commonly increases or rises in them. So patient might move around, or maybe he's moving the head region or something. The pain might increase. So it's aggravating on movement. That's the last A in there. Please don't forget the puma thing is not all 4 to be present. 2 or more than 2 are sufficient to call it as migraine. So it can be just pulsatile throbbing unilateral, that's it. That can also define as a case of migraine. Now don't forget this one. Any one of the four things that you can find. Any one of the two symptoms, that is nausea, vomiting, or photophobia, phonophobia. Look at the name, phobia. Fear means fear. Photo means light, phono means sound. So most of the time the patient doesn't want to talk to anyone, doesn't want to see the light. So if you've seen migraine patients, they will always be in the bed resting, doesn't want to talk to anyone, and they will switch off the light also because they've got photophobia. Don't forget, the most common presentation in a patient of migraine is considered to be nausea. Nausea happens to be the most common presentation of migraine patient, apart from headache, of course, as a symptom. Now, if I want to make a list from a study, the most common symptom apart from headache in a patient of migraine is nausea, followed by photophobia as a symptom, followed by light-headedness, and then scalp tenderness. Look at this. Can you tell me one disease which we just now saw scalp tenderness as a symptom? Yeah, giant cell temporal arteritis. Then we come with vomiting. See, why I'm telling this, because in 2019 NEET PG, we got a question that in a patient of migraine, apart from headache, what symptom is more frequently seen? And there was no nausea given in the case, in that MCQ. Everyone proudly marked the answer as vomiting, because if it's not nausea, it has to be vomiting. No, it's photophobia. So life is a race, don't forget them. Okay. I'll put this all into a very simple question, which is a very standard question that you will find. They ask like this: a female complains of a unilateral headache. A female complains of one-sided pain on the head region, and your great examiner will not mention the quality of headache. He will not mention it's dull, aching, stabbing, throbbing, nothing. Is very smart. Along with nausea as a symptom, what is a most likely diagnosis in this patient? So just few symptoms are seen. What is the most likely diagnosis in the patient? Remember this, if such a short history is given anytime any short history is given, please don't forget the answer number one has to be always what? Migraine. Any female patient who comes with a unilateral headache with nausea is nothing but your migraine. Okay. Number two, second differential diagnosis. Now I'll ask you this question. Tell me the second differential diagnosis you like to think about. And I'll give you that hint. It's an opthal emergency. It's an opthal emergency. Second differential diagnosis. Yes. Mukesh has answered it right. Mukesh Kumar. Second differential diagnosis. Good. Glaucoma. Thank God you are giving the right answers, because one batch I asked this question. They answered me, sir, conjunctivitis. I said, beta, nahi ho paega. Tumse nahi ho paega. Simple. Good. Now, people are asking me, sir, visual blurring will occur in migraine or not? Yes, it might occur. Now, there is a reason for visual blurring seen in a migraine patient. Now, we will go into that concept. How do we classify migraine? Now, there is a classification of migraine also known to us. The migraine is something which is classified on the face, which you know as aura. Aura is something which you remember in your classes of epilepsy, I've explained it, that it is something that we find as a preceding symptom to a disease, and most of the time they are hallucinations, right? Now don't forget, in patients of migraine, it's visual aura, more common than the sensory aura that you find with the patient. So visual aura is more frequently seen in these patients. Okay. Now there are two kinds of patients: migraine with aura and a patient who has no aura preceding the headache, migraine attack. Now migraine with aura, the answer is classical migraine. The name is classical migraine, the migraine which is with aura. Now migraine without aura, should I name it as Western, which is not classical or unclassical? No, the name is common. Okay, so there are some subtle jokes also, keep on laughing. Now 80% patients of migraine have no aura preceding the headache. They are known as common, they are very common, 80%. While 20% have aura, they are referred as classical. Okay, right? So it's very commonly asked question that most of the patients of migraine are preceding, don't have preceding aura, common. It's very common, 80%. Now the point comes in, there's another entity that we all should know, which has been asked recently. There's a patient of migraine who just presents with aura, that is known as the acephalgic migraine. Now find this out, name, acephalgic. That means the algic, as the name suggests, it's something that we find in the patient as a head pain, okay? So there's a head pain which is not felt in the patient. It's known as the word acephalgic, right? Now there's a patient of migraine who presents to me with aura only, but doesn't have any kind of a headache. Right? So aura is present prior to a migraine attack, but it doesn't have a headache. Is referred to me as a word acephalgic migraine. Okay. Now there's another concept. What is the most valid theory for migraine? Where has the student disappeared today? Abhi Gujarati bhai hamare, where are you? They were asking me what are the theories of migraine. No one knows it. No one knows it. He was continuously typing that thing. Now I'll come to your question. Don't worry. What are the theories of migraine that we have? Remember this. In theories of migraine that we have is the very first thing, there is always a trigger seen. There is always a trigger for a migraine attack to happen. Yes. And the trigger is multiple. It can be insomnia, that is lack of sleep. It can be stress, correct? It can be even bright light, correct? It can be bright light, insomnia, stress. It can be menses in females that we experience. And of course, something which is not routinely have in the lockdown period is red wine. Okay. So some cheers from your end. Red wine, insomnia, stress, bright light and menses. Few of them are mentioned as the trigger for a migraine attack to happen. Okay. Yeah, hunger also. Yes. Hunger also. Right. Now, what will this trigger start in? This trigger, always remember, goes and stimulates the sensory input of the fifth cranial nerve. The sensory input of the fifth cranial nerve is activated by them. Okay. Chocolate, no, I don't think so. Loud sound, yes, loud sound is also one of it. Constipation, yes, can happen. Menses, yes. Chocolate, I don't know. And coffee is always debatable. Okay, coffee, some authors write, some people don't write. But trigger is going to activate a sensory input of the fifth or the trigeminal nerve every time. Now, the fifth cranial nerve is going to carry the signal. And it is going to release certain vasoactive peptides. Now look at this. These peptides which are vasoactive are acting where? On the vessels. Okay. Now what happens is the vasoactive peptide which are very important here. Number one is CGRP. That's an abbreviated name and a very commonly used abbreviation of calcitonin gene related peptide. And even your substance P is being said into it. Vasoactive intestinal peptide, VIP also, and NO, nitric oxide. So VIP, substance P, NO, CGRP are some vasoactive peptides which are released out. Now what happens? When this vasoactive peptides are released, we are going to have vasodilatation in the vessels. Now look at this concept. The vessels inside the brain suddenly are going to dilate, and this vasodilatation is very commonly seen in the occipital region. Occipital region, okay? That means in the occipital lobe a lot of blood comes in. Because of this, what will happen? Suddenly in the patient you might see flashes of light. Flashes of light. Why? See, I'm having a normal vision. If I get more blood over there, I'm going to see flashes of light. No, somewhere what we find is this. In a normal vision, there are some flashes of light coming in. This phenomena, flashes of light coming in a normal visual field, is known as the fortification spectra. Fortification spectra. There is a light glaring up spectra, and we are adding something is known as the word fortification spectra. Okay. Now followed by a vasoconstriction also in the patient. Now just imagine the occipital vessels that we have are going to constrict now. Vasoconstriction is going to happen. So what is going to be seen? A black spot. And that black spot which comes in the field of vision is known as the scotoma. Scotoma. Okay. But don't forget, the worst thing is the vasodilatation that could happen in the patient. Now what will vasodilatation do? If you know the basic journal path, the vasodilatation is going to cause plasma leakage. Plasma leakage. And now what will happen? Now what will happen? The plasma leakage or the things which are coming out there are going to cause meningeal irritation. Meningeal irritation. And now this meningeal irritation is going to transmit the pain, or the headache will happen because of that. Okay. Now why vasoconstriction happens, I could not find a good reason given for that thing in the book. But vasodilatation, yeah, they genuinely give a reason for that. Now please remember, this kind of a drama or this kind of a theory will start in the occipital, will go into the parietal, will move into the temporal, and it might go into the frontal region like this. So it's, look at this. This kind of a thing, vasodilatation, will start in the occipital, go to the parietal, temporal and frontal. Maybe this progression can happen at the rate or a speed of 2 to 4 mm, okay, per minute across the whole cortex. So across the whole cortex, you might see in the patient the vasodilatation kind of a thing might progress like this. So we got a name given for this whole drama. Look at the name. I do not want to put the name first. See, a part of the brain cortex is getting more blood and is going to show me some positive signals, symptoms. Now look at this. Flashes of lights are the positive symptoms that I see something extra. Now look at this. Scotoma or a black spot is known as what? A negative symptom. That means I see a sudden black spot somewhere in the field of vision. Now what is the name of this theory? Can you tell me the name of this theory? Can you tell me the name of the theory, please? If someone can tell me the name, I'll be very happy. Now the name of the theory, I'll write it down, is cortical spreading depression. Cortical spreading depression. Or some of the authors have also written a name as dissociation, it's fine. Yeah, depression. Some people want to repeat. Okay, I'll repeat. It's a very important thing. No textbook actually. One student was after this theory because he knew, he's an intelligent student maybe. He knew this, that no author has given this theory well. I've read at least 4-5 books for this theory. Then I could gather what is happening. Now, if you understand this kind of a theory, you'll be able to recognize the treatment also. Now, I'll repeat. Cortical spreading depression, there is a trigger. Trigger is insomnia, stress, bright light, menses, red wine, hunger. I'm telling you the common triggers. This trigger is going to stimulate the sensory input of the fifth or the trigeminal nerve. Now, release of vasoactive peptides at the nerve endings is going to happen. And these vasoactive peptides are CGRP, substance B, VIP, and NO, nitric oxide. If you know, these vasoactive peptides are often doing what? Vasodilatation. Initially, it happens in the occipital vessels. Now, the normal occipital lobe is getting more blood. Flashes of light occurs. Now, flashes of light in a normal background is known as fortification spectra. Vasoconstriction could also happen. After that, that will result in a black spot. Flashes of light is a positive symptom. Scotoma is a negative symptom. But the problem is vasodilatation is something which is going to cause plasma leakage. And now the meningeal irritation will occur and the pain is felt because of that. And this wave from occipital, parietal and temporal and frontal would travel at the speed of 2 to 4 mm per minute all across the cortex like this. That's why it is spreading across the cortex as a wave of depression, cortical spreading depression. Now, why I'm telling this story? Because if you understand this, it's easy to remember the treatment. If I block CGRP receptor, yes, CGRP receptor is present on the vessel. If I block that receptor, correct? If I block this receptor, I can get rid of the problem. Can you tell me the name of the drug? Surname of the drug, I'll be very happy. I'll be very happy. You're attending pharma lectures also. One drug which is a CGRP antagonist now. Tell me the name. Yes, tell me the name. G-Pants, yes. Rohit Garg is will get a chocolate whenever you meet me. I'm seeing the students who are answering me first. I'm happy with them. Yeah, G-Pants, G-Pants. Good. Now, there is a meningeal irritation also occurring. Let me stop it. I can give this what? NaCids. The painkillers are very commonly used in migraine therapy. Correct? Another thing I can do, I can inhibit this vasodilatation from other end. Can you tell me another drug which is a vasoconstrictor agent which can inhibit vasodilatation and prevent the leakage of the inflammatory substance? Now tell me this name. A drug which is a VC, that means vasoconstrictor. Yeah, good. Triptans. Triptans. Okay, that's why one student was after my life from the beginning of the class. That's a no one books that tells me the theory. See, that's a real theory. It's the most accepted theory. If you understand this theory, you can easily remember the treatment part. Now, I'll ask you guys, what is the treatment for migraine? Good. If you understood the theory, the treatment of migraine is very clear and very simple. Now, I'll go into the basic again. Two more theories have been explained parallel to this theory. Two more theories have been explained parallel to this theory, which could easily tell me the good treatment for a migraine attack. One theory is the serotonergic theory. Serotonergic theory. Now, what does the serotonergic theory tells me? The 5-HT receptor are getting stimulated. Yes, sorry, are getting blocked. The serotonin receptors are getting blocked. Because of that, the vasodilatation kind of a thing is occurring. So one more theory which has been accepted also, apart from this serotonergic theory also, They say that the 5-HT receptor, if at all they are blocked, we can have a vasodilatation phenomenon. Correct. Now the treatment part is this. You give a drug which is a 5-HT receptor agonist, which can be of two types. Now don't answer me random. Whatever drugs you are having a jargon speech now. Serotonin. We'll go in a very systematic manner. Non-selective serotonergic receptor agonist, yes, and selective receptor agonist. Now non-selective, yeah, that's your non-selective one, which you know always remember that argotamine is a drug which is a non-selective 5-HT receptor agonist. Now looking into the selective category, two drugs, 1B and 1D receptor agonist, yes, and now the new drug which is a 1F receptor agonist. 1B and 1D receptor agonist, you always know this as what? Triptans. Now 1F, can someone of you tell me 1F receptor agonist? I'll be very happy. Yes, D-tan. Good. Lesmeditan. Please read this topic again from pharmacology. I might miss out few points, but this is a very high topic. Question is going to come. Triptans, a lot of triptans, you know. I did not write the names of even Suma, Riza, Zolmi, Eli, Flova, and all these triptans. Now, my question will be for you guys. Please tell me, out of all the triptans that you know, what is the best triptan? Okay, what is the best triptan? I'm asking you now. Let me clear this controversy also, because I've discussed with Ankit also about this topic. Yeah. Yes. Someone answered me, Sweta Singh. The winner is rizatriptan. Yes. Not Suma, it's Riza. Please correct yourself once more. Now, the best triptan in the patient is based on one thing which I know as the Tmax. Now, I will explain this from pharmacology somewhere, that the T-half is not the criteria to decide the best triptan. It's a Tmax that we take in. The time the drug takes it to reach the maximum peak and the time the drug is on the maximum peak is known as a Tmax. Don't forget, the drug of choice, DOC, anytime for treating an acute attack of migraine, is a triptan. Drug of choice for treating an acute attack of migraine is always a triptan, and that's a drug known as the rizatriptan. Okay. Now, I'll not go into the pharma part. Many drugs are oral, nasal, injectable. You can read it in pharma. Happy to be there. Now, a student came back with a doubt. Sir, no, I have read it in pharma guides and books that NaCl is drug of choice. You're telling me wrong. I'll explain this. The migraine attack occurs like a parabolic curve like this, as a parabolic curve. You know, this is something different now. Now look at these two curves. You know, when I give an NaCids, like is non-steroidal anti-inflammatory drugs, they might decrease the meningeal irritation. So they might decrease the intensity of the headache. But to bring down the headache to zero, you require the hero, that is the triptan, anytime. So anytime being asked, don't forget, the drug of choice is always a triptan. Okay. NaCids are not the ideal drugs. Triptans, rizatriptan is the drug of choice for treating an acute attack of migraine. Another good theory that we understand here is the dopaminergic theory. The dopaminergic theory. Now the dopaminergic theory explains somewhere. Dopaminergic central stimulation, yes, is going to cause one symptom in the patient very commonly, that is the nausea. So remember why nausea was a most common kind of symptom seen in a migraine attack, because the central dopamine receptors got stimulated. You want to explain the graph again? Okay, I'll explain it. The migraine attack, the headache of migraine increases and it settles down like a parabolic graph like this. It peaks and it settles down. Maybe the COVID pandemic should be like this only. We should peak and settle down fast. We'll be happy then. Now, NSAID is something which will bring down the intensity of the attack. And triptan is something which will bring it down to zero. So if I want to see this as a COVID epidemic, maybe hospitalization will only bring down the intensity, but the lockdown done by the triptan will be the best thing. Okay, so there is no better vaccine for COVID infection apart from the lockdown that we have presently. Okay, sad story, but in reality. Okay, so remember, NSAIDs in migraine are only going to bring down the intensity of the headache, while triptan is going to bring it down to zero. Right? Nausea. Treatment of migraine can be done by this dopaminergic antagonist. Dopaminergic antagonist, which is injectable as well as oral, known as the metoclopramide. Metoclopramide, injectable. Okay. So remember, the treatment of migraine is never complete without giving in a metoclopramide injectable to the patient. Okay. Now there are many bhakts in the crowd also. They are saying the triptan is our prime minister. Okay, fine. Prophylaxis. Tmax, someone wants to know this concept of Tmax. Tmax is something that is the time taken by the drug to reach the maximum peak and the time the drug is on the maximum level in the blood. That will be the deciding factor to take out the best triptan anytime. Okay. Now, prophylaxis. Prophylaxis of migraine is done if 4 or more than 4 attacks in a month occur in a migraine attack patient. So if more than 4 attacks in a month occur, yes, is prophylaxis. Prophylaxis is not for every patient of migraine. Remember this. If more than 4 attacks in a month happen, then you consider for prophylaxis therapy. Okay. Now, what are the drugs that we give, and what is the duration of therapy? 5 to 6 months time is the ideal duration of prophylaxis in a patient of migraine to be seen. Now, what are the drugs? The very first drug that we use here is beta blocker, and the beta blocker that we have is PMT. P stands for the propranolol, M stands for metoprolol, and T stands for timolol. 3 drugs. So when you entered MBBS, you might have given this old exam known as the PMT, and after that your life became what? LOL. So not all the LOLs, but these 3 LOLs are to be given. Second is a drug which we know as the anti-epileptic drug, which can be used in treatment or rather prophylaxis of migraine. 2 drugs, VNT. V stands for valproate and T stands for the topiramate. The third drug that we use is a calcium channel blocker, which is flunarizine. Don't forget the name, flunarizine. Number 4 is a drug which is a tricyclic antidepressant again. That is your amitriptyline. Right? So these are the few drugs which are used in prophylaxis of migraine patients. Yes. Now remember this question: the most widely used drug in prophylaxis of migraine patient is a propranolol therapy. Okay. Just a fact to add here: in females, I'm writing in females, severity of migraine decreases during one thing, pregnancy. Now someone was after my life, sir, what do I do in pregnant female? Arey Baba, all is well in pregnancy. The attacks of migraine, everything will settle down in females during pregnancy. Remember this point. And write it in a box separate. Don't think this pregnancy is a part of prophylaxis for migraine. Okay. Some bad jokes also. Regarding the doses, I am not going into the details of doses. They can be variable. Usually I start from 20 mg per day for propranolol. I can go to 240 mg per day also. Okay. Now, why does vomiting reduce pain in a migraine attack? Yeah, I know that. Because I've seen these patients, they come with headache and nausea. And if they vomit, the peak of headache settles down, maybe. With an episode of vomiting, we always say the migraine attack settles down. I've seen them. But I found that the part of nausea and the vomiting, when they were doing, they were at the peak of the headache. And suddenly it settled down. There's no clear reason. Not always a raised ICT phenomena, maybe. Okay. Right. Propranolol dose, people are asking me dose, write it down. It can be taken from 20 to 240 mg per day. Can be used in the patient. Now, don't forget something that we have with us nowadays as a new treatment modalities in patients of migraine. Okay. One drug which we know as the CGRP antagonist. I was talking about this drug, CGRP antagonist. Yes. GPANT. Yes, two GPANTs. Can you name the two GPANTs? Yes. One is the Remi GPANT and the second one happens to be the Ubro GPANT. Ubro GPANT. Remi and Ubro GPANT are the two drugs which are CGRP antagonists. Now you're confusing me. Erinumab and all, okay, they are CGRP what? Antibody. See, I'm not giving antibody in this GPANs. It's an antagonist, not an antibody as such. The CGRP antibodies. Now the CGRP antibodies which we have with us are Eri, New, Epti, Ni, Freemanes, and Gallesness. Now what do you add at the end of them? What is the surname of all these drugs? CGRP antibodies. What is the surname of all these drugs? Eri, Epti, Fremenas and Glassy. What is the surname? Map. Yes. Now why I'm giving it separate? Because I want to clear this confusion. CGRP antagonist as per the recommendation, yes, is given during the acute attack. CGRP antibodies, now clear this fact, is given for prophylaxis. So make it very, very clear. That's why I'm putting it quite separate from the list, because if I write in between, you might just get confused. Like you guys yourself are confused. Like Erinumab is a CGRP antagonist. No, it's a CGRP antibody used in prophylaxis of migraine. Now this is something important. Okay. Please read this topic again from your Pharmac textbook. I'll advise you to do that once because some of the Pharmac points are very important. The side effect and doses and all. Some person is asking me, say in my college, Monte Calci is given as treatment for migraine. See, I tell you the story. You know, most of the patients of migraine have got blocked nose or some sinus kind of an infection. So it's not too bad to treat that thing also side by side. There's nothing wrong in that. So you can go ahead with that. No problem. But that's not the actual line of treatment, please. Cluster headache. Cluster headache. Cluster headache is a headache which is more frequent in males than females. Remember this point. Role of antipsychotic Stemetel, even I don't know why every neurologist keeps on giving that, because I tell you the story. Most of the people of migraine have got vertigo and lightheadedness as a complaint. So just to suppress that symptom they give it, but it's not the proper kind of a treatment. Okay. Yeah, someone told me right. Sleep is the best medicine. Yes, migraine patient, remember this, will sleep off with headache. I always tell the patient of migraine to take some anxiolytic and go to sleep. You'll be all right when you get up. Okay. So in my clinical practice, I've treated many patients. Even I was suffering with migraine. I found later on, if I have insomnia, hunger, or something like this, or if I have red wine by chance, it's not available nowadays. Then in that case, I used to have a lot of migraine. I took a hell lot of treatment, but still, what I personally felt was the sleeping was the best medicine for a migraine patient. So many of you I know are suffering with migraine. Remember my word, sleep is the best medicine. Maintain your good hygiene of sleep, you'll be fine. You will not have recurrence of all. Ice cream is not a trigger. Not a trigger. No. You can have an ice cream. If you're having ice cream in a lockdown, you're very lucky. Okay. Triptans are not used for prophylaxis. Remember, triptans are most of the time given in a stage of an acute attack, not for prophylaxis. Okay. Cluster headache, cluster headache. Quick. Cluster headache is a headache which is coming to me in a pattern of peri and a retroorbital pain. Peri and retroorbital pain happens in the patient. Pain is around and behind the eye. Okay. And this kind of a pain is very commonly felt for a duration of 15 to 180 minutes. And apart from this, it's felt on one side, unilateral. Also in the patient, it is being precipitated by consumption of alcohol again. That's a trigger for cluster headache attack. Also in the patient, the pain is felt to be very commonly explosive. It's a very severe kind of a pain that the patient feels. And it awakens the patient from sleep. So remember this, peri and retroorbital pain which awakens the patient's sleep. So I repeat my words. Migraine patient will sleep off with headache, while cluster headache patient will often get up with headache. Okay. So it will awaken the patient from sleep. Remember this point. Now, don't forget, there are some autonomic symptoms also seen with them. Autonomic symptoms are seen in cluster headache patients, which are lacrimation and of course stuffiness in the nose known as the rhinorrhea. So as a complaint that they might come across with is lacrimation and rhinorrhea. And don't forget, these patients have got attacks, 1 to 8 attacks per day, and that would happen daily for a duration of 1 to 8 weeks. So it happens in the patient's life that daily for at least 1 to 8 weeks they are having 1 to 8 attacks in a day. Now look at this correlation, 1 to 8, 1 to 8 per day attacks daily for 1 to 8 weeks. Now what will happen in the patient is that a 1 year time will then come in when the patient will remain symptom free. There is no pain felt in the patient. Patient is found to be totally asymptomatic. So asymptomatic patient for at least 1 year time, and then the cycle repeats. So patient doesn't have a headache at all for a year time, and all these things now go into a phase like this. So why the name cluster came in? In cluster headache, what you find are clusters of headache occurring. That means a headache happens and it keeps on happening in a time, in a duration fixed, and then there is a gap of a year, and then again the relapse occurs of the whole story. So it's occurring in clusters together. That's why the name is cluster headache. Why asymptomatic? No clear reasons again. Somewhere they found that the lesion in patients of cluster headache is found in this part, hypothalamus. So hypothalamus is an area in the brain which is involved in these patients of cluster headache. Okay. So why asymptomatic? No clear reasons given again. But hypothalamus has been labeled as a site of the lesion in these patients. There was some hyperactivity going on there. Now going on to the treatment part, don't forget, for an acute attack of cluster headache, we give to them oxygen. Oh my God. Now don't ask me how does it really work, because even I could not find a clear reason given in any book for this. But they found that 100% oxygen is given at the rate of 10 to 12 liters per minute. For a duration of 10 to 15 minutes is sufficient. So for a duration of 10 to 15 minutes, 100% oxygen is given to the patient at a very heavy flow. And don't forget, the treatment of choice for acute attack of cluster headache is often considered to be a oxygen inhalation. Clear statements in our book. But other drugs are still available or are available with me. One of them is the sumatriptan. And in a study they have done vagus nerve stimulation. Vagus nerve stimulation, yes, is another technique applied in these patients, VNS. Now, how does all these things work? Not very clearly explained in any of the books, but for your knowledge, remember this: oxygen inhalation is the best treatment for acute attack. But now, very important, for prophylaxis of cluster headache, what do you do? First of all, write this down. Prophylaxis of cluster headache is given lifelong. Like in migraine, we were just giving it for 5 to 6 months time. Here we usually give it lifelong. Okay. Now for prophylaxis, there are many drugs given. The very first one is verapamil. Okay. Second would be a drug which is your steroids like prednisone. Third could be the old drug like lithium. So I'm just mentioning the names of few drugs which are used in prophylaxis of migraine, cluster headache. Now don't forget, the drug of choice for prophylaxis of cluster headache is always verapamil. Verapamil is the drug of choice for prophylaxis of cluster headache, and it's given lifelong. Okay, so two drugs, one drug for prophylaxis cluster headache is verapamil given lifelong, and one drug for acute attack is oxygen inhalation, right? Now we'll take a page out. I advise you to take a full page out somewhere. We'll put a heading here as trigeminal autonomic cephalgia TAC. Sorry, trigeminal, just rubbing it again, writing it, trigeminal autonomic cephalgia, TAC. Now if you want to read this topic, I'll make it simple. We'll make a table, okay, with maybe 4 vertical columns inside it, and we'll compare 3 disorders among each other. The very first is the cluster headache. The second happens to be the paroxysmal hemicrania, and the third is a very big name. Be careful. It is short lasting unilateral headache with CONG stands for conjunctival. CONG stands for conjunctival tearing. Short-lasting unilateral headache with conjunctival tearing. A very big name, but a very short term abbreviated known as SUNCT. Okay, short-lasting unilateral headache with conjunctival tearing, SUNCT. If you remember, SUNCT also is more than sufficient. Now remember this clear point. When I look at the cluster headache as a concept, yes, whenever I look at cluster headache, you already know the cluster headache is more frequent in males than females. That's one thing. Paroxysmal hemicrania is equally common in females than males, and same goes for the SUNCT. So just a clear difference between the three brothers under one roof of trigeminic autonomic cephalgia. Cluster headache is more common in males. Paroxysmal hemicrania and SUNCT is equally common in males and females. Now apart from this, we have this duration. The duration of attack is 1 to 8 attacks in a day for cluster headache, while in patients of paroxysmal hemicrania, it could be 1 to 20 attacks in a day, and here it is more than 20 attacks in a day. So look at this. When I'm going towards the right side, I'm increasing the duration. Sorry, I just wrote this thing wrong. Just rub this out. It's not the duration. I just wrote it wrong. Frequency. So when I'm going towards the right side, the frequency of attack is increasing. Now, very important difference again is the duration. The duration is 15 to 180 minutes. Here it is 2 to 30 minutes, while here it is 5 to 240 seconds. Right? Now look at this. As I'm moving towards the right side, I'm decreasing the duration of the headache in the patient. As I'm going towards the right side, I'm increasing the frequency of attacks which happen in the patient per day. Okay. Another quick difference is alcohol trigger, that it happens due to alcohol consumption. Yes, alcohol trigger occurs in cluster headache, not in the other two. So what happens on consuming alcohol or started is always a cluster headache kind of a thing. Don't forget cutaneous trigger. That is, if I touch the scalp region or the face region in the patient, the pain would actually rise up. Now, cutaneous trigger is seen in SUNCT, not the other two brothers. Right? And just a word on treatment. If you remember, oxygen inhalation. Oxygen inhalation was a treatment of choice for cluster headache, right? Now this was asked last year in NEET PG. Indomethacin, a drug, is working on a patient of paroxysmal hemicrania, and lidocaine. Now don't ask me how is it given. It's a very rare kind of a thing, SUNCT, but if at all we want to treat them, we treat them with lidocaine. So SUNCT, lidocaine is a treatment. Paroxysmal hemicrania, it's indomethacin. And don't forget the cluster headache is best treated with oxygen inhalation. One thing which I just forgot to write and someone pointed out me in between. Sir, in SUNCT the word N is missing now. Short lasting unilateral. Now the word N over here, please write it here. Neuralgia or neuralgic. The N stands for neuralgic now. So short lasting unilateral neuralgic headache with conjunctival tearing, like Ranchodar, Shamakdar, Chachar. Rancho is the name. Okay. Now the word cutaneous trigger means that when you touch the scalp or the face region, the pain actually starts rising in them. Paroxysmal is a word that means it's all of a sudden which occurs. Okay. Now, why are they put under one roof of trigeminal autonomic cephalgia? Look at this term. Trigeminal nerve was a nerve supply of what? If you remember this diagram, anterior and the middle cranial fossa. Yes, I told someone is asking, so what is the relevance of what you are telling me? This comes the relevance part. The fifth nerve happens to be the sensory supply of the skull, anterior middle cranial fossa. So there is a trigeminal activation, correct? There is autonomic activation also. That means all these brothers are going to have one autonomic symptom. What autonomic symptom? Lacrimation, rhinorrhea. And look at this name, cephalgia. That means there is a pain in the head felt in them. So next time if you see a patient with a periorbital kind of a pain with a lot of lacrimation and all, don't diagnose them as sinusitis or maybe conjunctivitis. Think about this rare entities also. Okay. Okay, I'll give you some questions just to end it all. Okay, I'll give you some questions to solve. Answer me these questions, they're very simple ones. Pseudotumor cerebri is commonly seen in which age group? Answer me this one. I'll answer your doubts at 9 p.m. You'll get more than 9 minutes to solve your doubts. So at 9 p.m., 9 minutes time for doubts. Now answer me this. A, B, C or D? Okay, I'll just enlarge it better. Pseudotumor cerebri is commonly seen in whom? Yes. A. B. What has happened to your knowledge of life in lockdown? You forgot everything. Arey Baba, it's obese female, but it is young. Who is young? 20 to 40 or 40 to 60? It is 20 to 40. Arey, what has happened to you guys in lockdown? See, 40 to 60-year-old female might think that she is young, but that's her perception. The best answer is 20 to 40. Okay. So that's an easy question, nothing. So I'm not being, I'm a feminist in this. Don't take any offense on this. Okay. Question number 2. A female has come to you with episodic recurrent headache in the left hemicrania. That is the left side of the skull, with nausea and right upper and lower limb. Oh, sorry, this got removed. I'm very sorry. Okay. A female has come to you with recurrent headache in left hemicrania with nausea and paresthesia in her right upper and lower limb. She is most likely suffering with what? Tell me answer. This question. Yeah. Recurrent episodic one-sided unilateral headache with nausea. Blindly mark it as migraine. Don't hesitate. It's always migraine. As I told you earlier classes also that what is the answer, why it is an answer, why not the other people? Now follow this. Glossopharyngeal neuralgia. The glossopharyngeal nerve is a sensory supply of the pharynx. That's why the glossopharyngeal, tongue, pharynx, sensory supply. Now what happens? Glossopharyngeal neuralgia patients are going to come to me with a throat pain. Odynophagia, painful swallowing kind of a symptom could occur in them. Not this kind of a headache would occur. Herpes infection of trigeminal nerve. Yeah. Someone was asking me this, a trigeminal neuralgia. You read in ENT about this. Herpes infection of trigeminal nerve will cause what? Trigeminal neuralgia. That will come with what? A facial pain. The pain on the face region could occur. Why not brain tumor? Look at this. Brain tumor. I agree, brain tumor can have headache, yes. But brain tumor patients have got raised ICD. With a vomiting, which I know as the projectile vomiting. Don't forget this word, projectile vomiting. Now, what is the meaning of the word projectile vomiting? Can anyone of you tell me about this? That means it goes to a distance like a projectile or a missile. Now, where does this vomiting go? If I take this vomiting somewhere in Delhi, okay, where I'm right now, will this vomiting go to Mumbai, or will it go to Mars, or will it go to Moon? Okay. Thank God you guys are intelligent more intelligent than me, because in my MBBS days I told sir it will go to some distance. Then the examiner asked me, sir, what distance? I said, sir, it might go to you only. Okay. So don't take this joke seriously, but it happened in my Viva. So remember, the vomiting which is not preceded by nausea, okay, is defined as a projectile vomiting. Okay. So vomiting which is not preceded by nausea is known as projectile. So whenever you don't have a warning symptom like nausea, obviously you're going to hit it like a missile, Sure. Paresthesia, now genuine doubt. I'll send my vomiting to China. Pakka. Pakka China, I'll send my vomiting this time. China, I know, China should celebrate Navratri every month. Then only we are safe, We should make them Jans now. Then only we'll survive in this world. China should be made as a Jan nation. Only veg people. Okay. Migraine. Paresthesia. Paresthesia and migraine occurs. You know why? This paresthesia is tingling numbness. It can be a part of sensory aura. Aura occurred as a hallucination. Tingling numbness could happen in the patient prior to the headache. Okay. So sensory aura can present as a paresthetic complaint in a patient of migraine. So remember this, in all questions I've seen of headache, I've seen this very common constant thing with the examiner. He never tells you the full blown history. He'll tell you bits and bytes. So catch the keywords and try to solve these questions. These very simple ones. Okay. "29-year-old woman," question number 3. So please stop writing, concentrate on the screen. "29-year-old woman presents with frequent headache. Which of the following supports a diagnosis of migraine?" Now look at this question. Tell me the answer first. A, B, C or D? Yes. D. Throbbing headache, unilateral, which gradually develops, is nothing but your migraine attack. As I was trying to make that parabolic curve, if you remember. Yes. The parabolic curve, I was trying to explain, it gradually develops and settles down with time. Right? Now, headache, which is bilateral and described as a tight band. What is this known as? Yes, it is known as some amaurosis fugax. Don't panic, all is well. Okay, some amaurosis fugax is there. Don't panic, you'll be back. Tension headache. Onset of the headache is sudden and severe. Now answer me, what is B? Option B. Sudden and a severe headache felt by the patient. Like this was a graph of migraine. That means a headache occurred like this. It went to the peak and went down. There's a disease which comes to me with a headache which is sudden and very severe. I'll give you hints. It is a thunderclap headache, as if a thunderbolt has come and hit my head. Not SGH, it's SAH. You read with me later in the live classes somewhere the topic of SAH. That sudden severe headache, a thunderclap headache, is seen in patients of SAH. So that is a diagnosis of SAH would be better. Okay. Question number 4. Another very clinical one, but an easy one. Which of the following does not require urgent neuroimaging? As I told you earlier also, when you don't know the answer, play safe, rule out every option and find the best answer. Okay. Headache. Okay, we'll go with this one. New onset progressive headache in a 60-year-old female. Elderly people with a new onset increasing headache on daily basis, progressive. Remember this, if you have this kind of an elderly patient who comes and complains you that my headache is new and it is progressively increasing, I agree. Some people might say, okay sir, giant cell arteritis, good catch, very good. Giant cell temporal, you can think, but do you diagnose temporal arteritis by neuroimaging? No, but I'm more worried about one more thing. Yes, tumor. Any kind of a brain tumor could occur. You have to rule that out thing first. Tumor, brain tumor, intracranial space occupying lesion. Now option C. 20-year-old male with sudden onset severe headache with neck rigidity. Arey wah, this is nothing but my Subarachnoid hemorrhage. Correct? Urgent neuroimaging, CT is required. Headache in a 30-year-old mother of a 1-month-old infant. Look at this now. She has delivered a baby and she is postpartum. And she is having a baby which is 1 month old. Should I do urgent neuroimaging in the patient or not? What are you suspecting first of all? Why is she having headache? She is having headache due to what? Baby, 1 month old. Yeah, babies do give us headache. I have 2 babies. See, it's actually a disease which you should be aware of. That is cerebral venous thrombosis. Very common in the partum and the postpartum period. So to know and to rule them out, we have to get a venographic study done. So it will be very helpful for them. Okay. No, not depression and all this. So that has to be ruled out by clinical examination. Now, what are we left with? Headache in a 15-year-old female. Doesn't require a neuroimaging so urgently as compared to the other subjects in the question. Now tell me, headache in a 15-year-old female, what are you thinking about? What are you thinking about? What are you thinking about? Insomnia, okay. Please remember, in adolescent people, one thing which is very common is what? Yes, refractive error. So something we are very much worried about in these patients is a refractive error. We need to rule that out. Refractive error, okay. So for refractive error, don't go for neuroimaging, go for ocular imaging or maybe a Snell chart and an eye testing. Now look at this question. 55-year-old woman experiences a sudden onset, new, unusually severe headache of generalized nature, the type which she has never experienced. The patient is admitted to the local hospital and it happens to have an acute elevation of the blood pressure. Which of the following is the most likely source and basis of headache experience in her? That's a very simple one. She has never experienced this headache. It's unusually severe headache. It is generalized all over. And there is some high BP also found on her. Tell me, 55-year-old woman. What can be the reason? Subarachnoid, migraine, intracranial mass or trigeminal neuralgia? Good. Subarachnoid hemorrhage. Sudden onset severe headache, I repeat, is nothing but SH in the history. Always try to catch these points out. Now this acute elevation of blood pressure is important. If you remember, there is a berry aneurysm in the circle of Willis and its rupture is going to cause SH and sudden onset severe headache. Now what happens is this. Suddenly what happens is that whenever there is a high BP, hypertension, there is going to be rupture of this berry aneurysm, and the rupture of berry aneurysm is going to ultimately cause what? Subarachnoid hemorrhage. That's the connecting part of it. Although I agree there is no neck rigidity symptom given in the case, but still I'll go with SH as the best answer. Now find this question also out. It's a very simple but still confusing kind of a thing. 60-year-old gentleman presents with complaints of headache. Okay, so what we have is the information with us. The patient is an elderly patient. Okay, and he is a retired army officer with good health, physically quite active, and apart from it, no addiction. Now he is retired at the age of 60 from army. He is not a retired medical officer who is in a bad health, physically quite inactive and has a lot of addiction. Okay, so he's a medical officer. No, he's a retired army officer, well disciplined in life. He complains that his headache is bitemporal throbbing, worsens on lying flat. He feels better on sitting upright. Now find this out. Patient lies on the bed and the pain rises. Maybe indirectly the examiner wants to complain a sign known as scalp tenderness seen in the patient. Because when I lie supine or maybe in the lateral position in the bed, the pillow comes in contact with the scalp and that pillow hits the scalp and increases the pain. Correct? It's a throbbing pain. Now, that's important, throbbing bilateral pain. And this patient also feels feverish but has never documented any elevation of temperature and his appetite seems to be suppressed. So in this very case, what we find, the temperature is high, nausea and suppression of appetite. That means something is cooking inside, that is inflammatory, known as itis. What is your best answer? Correct answer, rhythm correct all over the nation. Temporal arteritis. Temporal arteritis. Correct. But I'll ask you, why not the other people? Migraine can be a throbbing headache. I agree. But migraine, I keep on stressing on one thing. Most of the time the headache is felt on one side only, unilateral, not bilateral like this. Chronic tension type headache will very often be felt as a band-like sensation on the head, not a throbbing kind of a pain like this. So it's a very simple, straightforward question. Okay. And remember, tension headache was having what? Depression along with them. Do you think this patient is having depression? No. Although he has retired from the army, but there is no addiction in his life. So no addiction means no depression. Fit and fine person. The last question. What is false about cluster headache? Central pacemaker neurons in hypothalamus are involved in the pathology. Yes, the lesion was in hypothalamus. Periodicity is a core feature. Option B, C. At least one daily attack of pain recurs at the same hour of each day. Yes, this can happen. Associated with ipsilateral cranial parasympathetic autonomic activation. Yes, this could occur. But what I find something fishy is this bilateral photophobia and phonophobia. Some of the authors do give in cluster headache, you might see it. But I feel that this is something going with an episode of migraine, not a cluster headache case. So there is a unilateral parasympathetic autonomic stimulation causing lacrimation, rhinorrhea. Central pacemaker is in hypothalamus. Periodicity of attack occurs, there are clusters seen. And there is unlikely to be any kind of a photophobia or phonophobia seen in them. Okay. In the previous, that retired army officer, there is option D also. I just forgot to mention this. Tender points, fibromyalgia, if you know. You can read this topic somewhere from Rheumat and Orthopedics. In these patients of disease known as fibromyalgia, there are tender points felt. So that means when you press the scalp, maybe a back, neck region, any point, the pain suddenly starts rising, tender points. Okay. Yeah, periodicity is a core feature. That means it occurs at the same time of the day. It occurs in clusters. That's a core feature in them. Okay. Oh, we are almost 11 minutes extra. Oh my God, you studied so much. Oh, 9-11, James. So any doubts, any queries, most welcome on the FB Club 2020. I'll just put down a post. I'll put down a post. Wait for another 5-10 minutes. You're most welcome. I'll solve all the all the doubts over there. Okay, because it's very difficult to solve it on the chat box. Okay. Yeah, hungry because you all might have migraine. It might trigger migraine. That can be very fatal for you guys. Okay. Tomorrow we will see a topic, neuromuscular junction disorder, myasthenia gravis. We'll deal with that. See, headache was not that much clinical. I still took out that topic because it's very high yield for the exam. Tomorrow another very important and a clinical topic we'll go and see. It's myasthenia gravis. Very interesting. Okay. Okay. Chalo, good night. Stay safe. Stay at home. And after the lockdown gets over, we'll see what to do of China also. Okay, we'll make them Jan up, so they celebrate Navratri every week over there. Okay, so good night.